Hello, dear friends, colleagues. Welcome to this PCR session on the outlook on TAVI in Asian patients. How can the Navitor valve with the FlexNav delivery system enable successful procedural outcomes? I am Michael Lee from Hong Kong. Joining me tonight would be Dr. Ravinder Rao from India, as well as Norio Tada from Japan. So the objectives of tonight's session would be to enable us to understand the special anatomical features of the Asian aortic valve stenosis patients and learn how to manage tortuous and small anatomies, and then understand how the design of the TAVI valve actually influence the hemodynamic outcomes and long-term patient management. So from the Chinese population, we understand that the iliofemoral artery of the Chinese population, which is representative of the Asian patients, are actually significantly smaller than the Caucasian counterparts. This actually makes the delivery of the TAVI device much more difficult when you have to negotiate a smaller iliofemoral artery, and a lot of these patients are small build, making the iliofemoral arteries very tortuous, and sometimes in elderlies with calcium would increase the difficulty in delivering the TAVI catheter. If you look at the Asian population again, it has been shown that the aortic annulus as well as the aortic root anatomy are actually also smaller than the Caucasian counterparts. This has been reflected by the smaller sinus size and also lower coronary height in this particular paper. And if you look at the Japanese Ocean TAVI registry, we can see that the annular size of the Japanese, which is another representative of the Asian population, is actually much smaller than the Caucasian counterparts again. So in this particular population in Asia, we have smaller aortic root, smaller sinus, as well as smaller aortic annulus. The other problem is the amount of calcium. We notice that especially in our Chinese patients, we have significantly higher calcification in the aortic annulus as well as the leaflets as compared to the US as well as Caucasian population. This calcium actually increase the difficulty of placing properly an aortic device, both in terms of the pre-dilatation, post-dilatation, and symmetry of the aortic valve device at the end of the procedure. And what's more important is this a lot higher incidence of bicuspid aortic valve in Asia, as well as in China and other parts of Asian countries. If you look at the Chinese population, nearly 30 to 40% of the TAVI patients are actually having the bicuspid anatomy as compared to other parts of the Caucasian population. In fact, in other parts of Asia, like in Hong Kong, we have slightly lower instance of bicuspid aortic valve, but still we have about 15% of patients are having bicuspid annulus. So if I can sum up, in Asian anatomy, we have smaller iliofemoral peripheral arteries, smaller sinus, smaller annulus, more calcification, as well as a higher instance of bicuspid aortic valve. These are some of the special characteristics of the patients which would facilitate further discussion on the choice of TAVI device by the following speakers. Maybe I can stop here and seek some opinion from our two experts on how we can actually manage our Asian patients. Maybe I can start with Dr. Rao. We've seen the Japanese and the Chinese data with smaller anatomy. Do you see the same in India?
Dr. Lee, great presentation, and that is exactly what we are seeing. The incidence of bicuspid patients, bicuspid aortic stenosis in our TAVR cohort is around 33%. But let me ask you one more question. The average age of the TAVR cohort in India is 72 years, and that is exactly what I saw in your presentation. But the average age of the cohort in the Western world is around 80 years. Do you think that this incidence is more because we are treating a decade younger patients compared to the Western world? And I mean, that's definitely we are getting a different type of bicuspids, and I totally agree as what you presented, more calcification and some different type of distribution of calcification. These patients would have calcium on the raphe all the way till the base of leaflet, LVOT, and what you presented is exactly what we see: small femoral vessels and very eccentric and large calcium distribution. So, do you think this is just because the average age of these patients is a decade younger compared to the Western world?
Yes, I agree that the average age, if you look at the Chinese registry, actually the average age is about 8 to 10 years younger than the Caucasian cohort. But we still don't know the exact reasons why we see so many bicuspids in the Chinese population. I think age is part of the reason, and there are some unexplained reasons behind that we need to dig into more in future registries. But this is the fact that we are seeing a little more bicuspid anatomy, as well as small anatomies, more calcification in our population. The other reason I would guess with the higher calcification is we have a much higher instance of diabetes, which might actually end up with earlier instance of chronic renal impairment. And this might actually increase the incidence of calcification of the aortic annulus as well as the leaflets.
And we see more of type 0 and type 1 bicuspid aortic stenosis. And some of these series, the type 0 is almost equal to type 1 bicuspid aortic stenosis, which is less in the data which we get from the Western world. And in my own experience, and also from experience from other expert operators in our country, the type 0 bicuspid has been behaving similar to a tricuspid aortic stenosis. The outcomes are no different. But when it comes to type 1 and type 2, it becomes more challenging. And sometimes we have to optimize the TAVR procedure in terms of choosing the valve, choosing the wire, optimizing the depth, and doing a post-dilatation.
Yes, I agree. That's why we have to choose the appropriate device for a particular anatomy. So let's turn to you, Dr. Ravinder Rao. Let's talk about the small iliofemoral arteries, how to manage access and delivery. Please go ahead.
So I'm going to start exactly from where you left, sharing the femoral vessel size, where you showed the comparison between the average femoral vessel size of the Caucasians and the Southeast Asian and Chinese population. We definitely see small femoral vessels, the vessels which are heavily calcified, tortuous, and I'm going to highlight this point based on the one CT scan and case which I'm going to share with you. And here you can see a heavily calcified, tortuous external iliac and common iliac artery. And you can see there are more than 290-degree bends, and there's calcification at the bend. And you know how the entire data which is coming out based from the ACC, AHA, as well as the European guidelines, that it is the transfemoral TAVI, which is a class 1 indication. And non-TF TAVI is actually a class 2B or 2A. So now we have to optimize our TAVI procedure in such a way that we are able to do a transfemoral approach. So this is an example where a FlexNav catheter was delivered through what we call it as a hostile anatomy and the iliac vessels. Here the angiogram, and you can appreciate the tortuosity based on the wire and calcification. So even in this hostile anatomy over a stiff wire, And after delivering a 14 French sheath, the FlexNav catheter could be easily negotiated. And this was the final aortogram with no paravalvular leak and no gradients. So the only point which I wanted to highlight with this presentation was how we can optimize and choose the right valve so that it can be delivered safely from the femoral vessels and iliac vessels uh, with no vascular complications or minimum vascular complications.
Thank you, Dr. Rao. A great case, and I would suggest this is a very, very difficult anatomy to tackle with the ordinary TAVI device. Very tortuous, calcified iliofemoral arteries. Dr. Tada, do you see this such tortuous, calcified, and small iliofemoral arteries in Japan as well?
Yeah, the same. That with the same that small vessel and tortuous anatomy.
So usually, how do you tackle this sort of anatomy?
Usually the Navitor's sheath is very nicely advancing in such a tortuous anatomy, and the sheath is more hydrophilic and easily goes through the small vessel.
And Dr. Rao, we know, of course, the catheter itself is important. The FlexNav actually allow more flexibility and deliverability. But I think the guide wire actually helps quite a lot as well. And when you encounter a lot of calcium, sometimes accessory device such as the shockwave balloon might sometimes also be helpful. How often do you need to use extra stiff guide wire or even the shockwave balloon to help you out with the delivery of the TAVI catheter?
So answering your first question, we would first put a JR diagnostic catheter, and inside a JR diagnostic catheter, we would, in such a tortuous anatomy where there is more than 290-degree bend, we would go upfront with a Lundquist wire to put our big sheath in. Now, if there is a tortuosity and the vessel dimension is less than 5 millimeter with a circumferential calcium, we have done an IVL balloon using a 7 millimeter balloon and give a lithotripsy, do a pre-dilatation, then advance the sheath. Post-procedure, once the valve is deployed, we will do a peripheral angiogram. And if there is no flow-limiting dissection, that's how we would leave it. We would not put any stent in it. But to answer your question, at our center, we are yet to do a non-TF approach, though we started our TAVR program in 2018. It's 100% transfemoral, and I would tell my patients, I would first tailor the valve to your femoral artery and iliac vessels. And that's how we would do a TF access for all our TAVR patients.
Thank you, Dr. Rao. Maybe we continue with Dr. Tada's presentation on how valve design can influence the long-term outcomes of our TAVI patients.
So Dr. Lee, thank you for introduction. So I will talk about the two special valve design for long-term outcomes. The first one is a single-digit gradient. So let me show my case. That this is a 80 years old lady of the severe aortic stenosis. Her annulus area was 350 millimeter square, and the perimeter is 63 millimeter. So it's a very small valve. And the sinus of Valsalva is 23 to 26 millimeter, and the coronary height is lower than 10 millimeter in both coronary artery. So this anatomy is very small anatomy. So we implanted the Navitor 23 millimeter valve. See the aortography. Navitor smoothly fits the valve, and the power leak was trivial. Both coronary artery was not obstructed. Surprisingly, the echo before discharge showed mean gradient was 8 millimeter mercury, and the effective orifice area was 1.9 centimeter square. So how can you imagine such a small gradient? The answer is non-tapered stent design. In another word, it's a straight frame. inflow diameter is equal to the outflow diameter, which contribute to producing large effective orifice area. Qualab echo data shows that at the 30 days after TAVI, Navitor's mean gradient was 7.4 millimeter mercury and 2.0 centimeter squared as an effective orifice area. The second characteristic is easy coronary access. For the future coronary access, Navitor has two characteristics making coronary access easier. It's a large cell geometry and intra-annular valve design. Our hospital have reported a novel technique for coronary access using end-face view. Basically, coronary access has been performed using perpendicular view, but the perpendicular view shows long axis of the valve. End-face view tells us short axis orientation. This is how to make end-face view, see the fluoro, and go to RAO cranial. Usually, optimal angle of the end-face view is deep RAO cranial. In this case, RAO 66 degree and cranial was 9 degree. This is a case of coronary access after Navitor implantation. Left panel is perpendicular view and the right panel is end-face view. Navitor has large cell and intra-annular valve, so it's very easy to achieve selective engagement. For the right coronary access, we need to do clockwise rotation to get there. End-face view tells us short axis orientation, therefore we can understand how much we need to rotate the caster. This is left coronary access. Actually, in this case, commissure is in front of the left coronary artery. So coronary access was considered to be difficult because there is inner calf at the commissure. However, end-face view tells us the location of the commissure from the three tab and commissure attachment feature. Using the end-face view, we get the caster through just posterior the commissure and achieve selective engagement. So now I introduced two great valve design of Navitor for long-term outcomes. Thank you very much.
Thank you, Dr. Tada. Great presentation, and you highlight two very important elements of the TAVI design that can enable better outcomes in the future. A quick question to Dr. Rao. As we move to a younger and lower risk patients, how important is this lower gradient, bigger effective orifice area, as well as easier coronary access important to these younger and lower risk patients?
These are two very important points, Dr. Lee. As you highlighted, the Southeast Asian population is at increased risk of coronary artery disease. There's so much of diabetes and other risk factors. And as we move from low risk and younger age group, repeat TAVI procedure for sure at 10 to 15 years of age and coronary reaccess becomes very important for such patients. Now, long-term data, the longevity of the valve also depends on the baseline hemodynamics. So we try to optimize the valve so that post-procedure, there is single-digit gradients and easy coronary access. In my opinion, it is even more important in low-risk and young patients.
We have very special Asian anatomies, which include a small tortuous and a lot of time calcified iliofemoral peripheral arteries, small aortic root, sinus, as well as small annulus, sometimes with very heavy calcification, and a high incidence of bicuspid aortic valve anatomy, which actually increase the difficulty of placing a proper TAVI device in the correct position. And Dr. Rao actually showed us how the FlexNav has enabled better flexibility and delivery of the TAVI catheter through a tortuous, calcified, and small iliofemoral anatomy. Lastly, Dr. Tada actually had shown us how the valve design can actually impact the long-term outcomes of our TAVI patients in terms of both low gradient, single-digit gradient, and large effective orifice area at the end of the TAVI procedure, as well as a large cell design, which would actually enable easy and future coronary access for our lower risk, younger TAVI patients. I think we have a very fruitful discussion. Thank you very much, Dr. Rao, Dr. Tada, for the contribution, and hope we can meet each other very soon in the near future. Take care and have a good day.